All right, welcome back to the deep dive. Today, we're really zeroing in, taking a specific condition, croup, and pulling apart some MSRA pediatric revision notes.
Mm.
You know, that laryngotracheobronchitis thing? Sounds serious, but it's that classic barking cough.
Mm-hmm.
Our mission is pretty straightforward. Pull out the absolute must-know info straight from these notes, make it clear, sticky, get those key facts locked down for your revision.
Yeah.
Think of this as like your shortcut through this specific material on croup.
And focusing like this, just on the notes provided, is actually really, really good for revision. Helps you nail down what's likely to pop up, streamlines things.
Okay, let's dive right in then. What do these notes actually say croup is, the core definition?
So, fundamentally, it's described as a viral infection, upper airway. And specifically in young kids, they give that age range 6 months to about 6 years.
Viral infection.
Yep.
And the cause is listed. Mostly viral, I assume.
Oh, yeah, definitely. Primarily viral.
Mhm.
The notes mention things like parainfluenza, RSV, influenza, usual suspects.
All right. And I saw something about two types, viral croup and spasmodic or recurrent. What's the quick difference there, according to the notes?
Yeah, the distinction they make is really about the symptoms. So viral croup, that's your classic bark and cough, hoarse voice, and stridor.
Okay.
Spasmodic croup, though.
Okay.
It's described as mainly just the barking cough. You don't typically get the other big features like the stridor or significant hoarseness.
Got it. So focusing on the main one, viral croup, what are those absolute hallmark symptoms jumping out from these notes?
It's that classic triad, really. The characteristic barking cough sounds like a seal, people say, a hoarse voice, and crucially, stridor, that noisy breathing, especially when breathing in.
Stridor. Right. And diagnosis, how do the notes say that works?
It's clinical, based on those signs and symptoms you see and hear, and they specifically flag stridor as like a key indicator, not just of croup, but how severe it might be.
Okay, so stridor equals pay attention.
Definitely. And while we'll get into the management details later, the general approach mentioned is, supportive, fluids, maybe some humidified air. And then for the more severe end, it mentions corticosteroids and nebulized adrenaline.
And prognosis?
Generally okay.
Yeah, generally good. Mostly mild, self-limiting is how it's put.
Yeah.
But they do mention that rare complication, upper airway obstruction, it can happen.
Okay.
Oh, and a quick memory tip. That long name, laryngotracheobronchitis.
Yeah.
Let's break it down. Larynx, trachea, bronchi. It tells you exactly where the inflammation is happening according to these notes. Helps picture it.
Larynx, trachea, bronchi, inflammation. Yeah, that's actually pretty helpful. Okay, let's dig a bit deeper into the causes. The notes get quite specific on the viruses, right?
They really do. They emphasize parainfluenza viruses, types 1, 2, and 3, apparently responsible for like 75% of cases.
Wow, 75%.
Yeah, and human parainfluenza virus 1, HPIV1, is singled out as the most common one within that group. HPIV1, 75%. Okay, that feels like a high-yield number from this source. Definitely one to flag. What else is on the list?
So other viruses mentioned are influenza A and B, adenovirus, RSV, rhinovirus, even enterovirus. So it's not just HPIV1, but that's the big player.
And they briefly mentioned bacteria, Mycoplasma, diphtheria.
Yeah, less common causes. But the key practical point in the notes is that the type of bug virus or bacteria doesn't actually change your initial management steps.
Right. You treat the presentation first, based on these notes anyway.
Exactly.
Okay, now this is the really interesting bit for me. How does the virus actually do that? Cause those scary symptoms? What's the pathophysiology described here?
Okay, so the notes lay it out pretty clearly. The virus likes the subglottic region and the laryngeal mucosa, so that bit just below the vocal cord.
The glottic, okay.
And it causes inflammation there, swelling or edema. Now, in little kids, that airway is already pretty narrow.
Right.
So the swelling makes it really narrow, significantly restricts the airway lumen.
Okay, so inflammation, swelling, narrowing.
Yep. And that narrowing messes with air movement, especially breathing in, when the pressure difference kind of sucks the narrowed walls together even more.
Ah, okay.
And that impaired air movement leads directly to the respiratory distress and that distinctive sound, the inspiratory stridor. So yeah, inflammation leads to narrowing, leads to symptoms. That's the core idea in these notes.
That makes complete sense. Inflammation, narrowing, stridor. Simple, but effective explanation. Okay, shifting slightly. Who's most likely to get croup? What risk factors are we looking at in this material?
Right, risk factors, age is the big one. Peak incidence, the notes say, is between 6 months and 3 years old.
6 months to 3 years. Prime time.
Definitely. Other things. Exposure. Being around someone who's already got it makes sense.
Sure.
Lack of prior immunity to those specific viruses. And, going to daycare or school, more
Right.
exposure opportunities.
I see. Exposure, age, anything else?
They mention a slight gender thing, a bit more common in boys.
Yeah.
Ratio is about 1.4 to 1, male to female.
Huh. Okay. And then there was that kind of random genetic detail, something about CD14C159T.
Yes. The CC variant of that gene, associated with a lower prevalence. So having that variant seems slightly protective based on this source.
Weird. Okay. A fun fact, maybe.
Yeah, maybe not top of the revision list, but it's in there. For remembering the main risk, maybe just a quick mental checklist. Age, exposure, daycare, gender, something simple like that.
Age, exposure, daycare, gender.
Got it. So how common is this overall, and is there a season for it? What about the epidemiology numbers in the notes?
Well, they describe it as common in children, reinforcing that peak age, 6 months to 3 years.
Yay,
And they give a figure for annual prevalence. Around 3% of kids get it each year.
3%.
And seasonality. Yes, definitely. Highest incidence is in autumn. And hospital admissions specifically peak between September and December.
Autumn peak, Septidec for admissions.
Exactly. Though, it can happen anytime. But that's the main season.
Okay.
For remembering, maybe just link autumn and admissions peak September. Autumn admissions.
Yeah.
Catchy enough. All right, let's get practical. Picture the scene. What does a child with croup actually look like based on these notes, the clinical features?
So the typical picture they paint is that barking cough we've mentioned, hoarseness, inspiratory stridor, often heard when the child is resting, maybe a low-grade fever, and signs of respiratory distress, breathing fast, pulling in at the chest or neck muscles.
Okay, that works.
And they make a specific point. Symptoms often get worse at night, or if the child gets upset or cries, that nighttime worsening is really characteristic.
Right, the midnight bark.
Yeah.
We said diagnosis is clinical, maybe starts like a cold,
Right.
but that's stridor. That's the key differentiator, yeah. And points towards severity.
Absolutely. Stridor is the big flag. And these notes give a really useful way to categorize severity. They break it down into mild, moderate, severe, and then the really critical one, impending respiratory failure.
Okay, let's break those down. What defines each level according to the notes?
Right. So, mild croup. You've got the barking cough, maybe some hoarseness. And this is key, no stridor when the child is calm and at rest. Maybe a little bit of chest wall recession, maybe a bit lethargic, but no resting stridor.
No stridor at rest. Mild. Got it.
Moderate croup, you've got the bark, the hoarseness, and stridor that's audible even when the child is resting. You'll also see definite chest wall recession. But the notes specify no significant agitation or marked lethargy. They're distressed but not agitated or floppy.
Stridor at rest. Recession, but not agitated. Moderate. Okay.
Severe croup. All the above bark, stridor at rest, recession, plus the child is either agitated or significantly lethargic. That change in their mental state, combined with the other signs, bumps it up to severe.
Okay, agitation or lethargy is the marker for severe.
Exactly. And then impending respiratory failure, that's the most serious. Signs include increasing difficulty breathing, the child getting obviously tired out, maybe starting to look bluish or dusky cyanosis, decreased consciousness, or their heart rate going really fast, tachycardia, the body struggling to cope.
Wow, okay. That's a very clear progression based on stridor, recession, and mental state. So what does that assessment immediately tell you about next steps? According to these notes, where do they go?
It basically dictates hospital admission. The notes say admission is required for moderate or severe cases, definitely for impending failure, and also if there are other high-risk factors present.
Okay.
They also mention considering admission even for mild cases if certain risk factors are there.
Right, so for revision, maybe flashcards or a mental checklist based on those signs. Cough, stridor at rest, recession, agitation, lethargy. Helps you categorize.
Yeah, absolutely. Linking stridor plus recession to moderate severe is a good starting point.
Okay, so diagnosis is clinical. But are investigations ever needed, or is it generally avoided initially based on these notes?
The notes definitely emphasize clinical diagnosis first and foremost, but they do list situations where investigations might be useful to help manage or maybe rule out other things.
Like what?
Well, pulse oximetry, checking oxygen sats, and SO2 below 95% is flagged as significant.
Okay, O2 sats. Makes sense.
Imaging like x-rays or maybe neck ultrasound could be considered in severe cases, or if the presentation is a bit unusual, atypical.
Right.
A rapid flu test is mentioned as a possibility. Maybe a flu is circulating, but they add a practical note that doing the swab can be quite distressing for a child who's already struggling to breathe.
Fair point.
And then laryngoscopy, actually looking down with a scope that's really reserved for atypical cases, or if you strongly suspect something else is going on, like from that differential list.
Okay. What about that classic X-ray sign people talk about with croup? Is that in the notes?
Yes, the steeple sign, it's mentioned, seen on a front-on-chest X-ray, a PA view. It shows that narrowing of the airway just below the vocal cords, the subglottic area, looks like a church steeple tapering upwards.
Steeple sign. Got it.
And importantly, they contrast it with the thumb sign. That's seen on a lateral neck X-ray from the side. It shows a swollen epiglottis, looks like a thumbprint. That's the sign for acute epiglottitis, a totally different, very serious diagnosis.
Steeple for croup, thumb for epiglottitis.
Exactly. Great visual mnemonic. Steeple tapering airway, croup. Thumb swollen lump, epiglottitis. Helps keep them straight.
Excellent. Okay, speaking of differentials, if it isn't croup, what else could it be? The notes give a list, right?
Yeah, there's a pretty comprehensive list of things that can cause similar symptoms, like stridor or breathing difficulty. Important to have these in the back of your mind. So what's on the list?
Okay, so epiglottitis, the big scary one. Bacterial tracheitis, another serious infection. Foreign body aspiration kit, inhale something small. Retropharyngeal abscess infection behind the throat.
Allergic reaction?
Yep, allergic reaction or angioneurotic edema, sudden swelling. Also things like vocal cord dysfunction, laryngomalacia, though that's usually younger infants with a different type of stridor, peritonsillar abscess or quinsy, and rarer things like laryngeal mucosal lesions or vocal cord paralysis.
Wow, quite a list. It is. But the notes suggest that the features of croup, that specific barking cough, the typical age group, usually help you differentiate. Like epiglottitis often has a muffled voice, drooling, looks really toxic, very different from the croup picture.
Okay.
For revision, maybe group them. Or definitely focus on remembering the life-threatening ones you absolutely can't miss. Epiglottitis, foreign body, bacterial tracheitis. Knowing those cold is probably high yield.
Right. Know the whole list, but really know the emergencies. Makes sense. Okay. We've diagnosed it. We've assessed how bad it is. We've thought about mimics. Now, the crunch time. Management. What's the plan according to these notes? This feels key for revision.
Absolutely. The overall goal stated is simple. Relieve the symptoms, provide supportive care.
And the main tools.
General strategies mentioned are hydration, keeping the child comfortable. Humidified air gets a mention, but they later note it's kind of anecdotal, maybe not super evidence-based. The core medical treatments are oral corticosteroids, and for the moderate to severe end, nebulized epinephrine adrenaline.
Okay, let's start mild. Kid doesn't need the hospital. What's the home management advice and the first prescription?
Right, so for mild croup, no hospital needed. The notes are very specific. Prescribe oral dexamethasone immediately. Dose 0.15 milligrams per kilogram.
0.1 Valevs per kilograms dexamethasone. Got it.
Yep. And then give safety netting advice to parents, signs to watch for, when to come back or call for help.
And the general self-care advice for home.
Pretty standard stuff. Paracetamol or ibuprofen if there's fever or discomfort. Encourage fluids, keep breastfeeding if they are. Check on the child regularly, especially at night. And arrange follow-up as needed.
Okay, that 0.15 milligram dex dose seems really emphasized for mild cases. What about the steroid options overall, and when does adrenaline come in?
So the aim of treatment is reducing that airway obstruction and inflammation. Steroids are key. The notes list a few options. Prednisolone, orally, 2 milligrams daily for 3 days. Or that single oral dose of dexamethasone, 0.15 milligram a kilom, that dose pops up again. Or nebulized budesonide, single 2 milligram dose.
Dex seems like the star here.
It does seem highlighted. Then moving up. For moderate croup, the notes say steroids plus nebulized adrenaline. The dose given is 5 milliliters of the 1 in 1,000 adrenaline solution via nebulizer.
Moderate steroids plus adrenaline.
Okay. And for severe croup. Steroids, nebulized adrenaline, and consider adding oxygen if their SATs are low. And the notes mention intubation might be needed if they progress to actual respiratory failure.
Got it. What about things not to do or stuff that's less proven? You mentioned steam.
Yeah, the notes reiterate home management for mild cases, and they specifically call steam use anecdotal, so not something they're strongly recommending based on evidence.
Oh, okay.
They also mention that only about 10% of kids with croup end up needing hospital support, and most who are admitted get better and go home pretty quickly after treatment, though kids with underlying issues might need longer monitoring. And persistent symptoms always need checking out.
And for real emergencies, what's the immediate go-to?
High flow oxygen and nebulized adrenaline. That's the immediate response mentioned for severe distress.
Okay. Now, there was a crucial bit about CKS recommendations.
Yes. This feels really important. The notes highlight the CKS clinical knowledge summaries recommendations. They state that a single dose of oral dexamethasone, that 0.15 mg/kg dose again, should be given to all children presenting with croup, irrespective of the severity.
All children, mild, moderate, severe.
That's what these notes specify based on the CKS recommendations. Prednisolone is the alternative if dex isn't available. That universal dexamethasone dose feels like a major take-home point from this source.
Wow, okay. 0.15 mg/kg dex for everyone. That's definitely one to remember.
Absolutely. So for revision, pillars are steroids, dex, adrenaline, moderate, severe, supportive care, and maybe map it out. Mild dex, moderate dex plus adrenaline, severe mild dex plus adrenaline plus O2 support.
That simplifies it nicely. Okay, nearly there. Prognosis. What's the typical outcome based on these notes? And any nasty complications to be aware of?
Generally, the prognosis is good. Most kids get better on their own in a few days.
That's good to hear.
And they break it down by severity again. Mild often resolves itself, but dex speeds it up. Moderate usually clears up fine without complications. And even severe cases do really well with the dexamethasone and adrenaline treatment. Excellent prognosis is the term used.
So even severe cases usually end well with treatment, but what are the rare worst-case scenarios mentioned?
The main serious risk is that severe upper airway obstruction we talked about, potentially leading to respiratory failure. The notes quote an intubation rate of about 1–3% for those kids heading towards respiratory failure.
Okay, small percentage, but serious.
And very rarely, death can occur. The rate mentioned is about 1 in 30,000 cases, so extremely rare, thankfully.
And other complications, things that can happen alongside or after.
Yeah, the notes list a few. Obviously, the severe respiratory distress itself.
Right.
Bacterial superinfection, like getting pneumonia or bacterial tracheitis on top of the croup. Pulmonary edema, pneumothorax, though likely rare. Things like lymphadenitis, otitis media, ear infections. And dehydration is common, just because it's hard for them to drink when they're struggling to breathe.
Okay, so watch out for secondary infections and dehydration, too.
Exactly. While the overall outlook is positive, you need to be aware of these potential bumps in the road.
Right. So let's tie this all together. We've gone through definition, causes, symptoms, severity, management, prognosis. Based purely on these notes, what are the absolute high-yield points for someone revising for the MSRA?
Okay, top points from this source. Know the age group, 6 months to 3, maybe up to 6 years. Know the main cause is viral, especially parainfluenza 1, that 75% figure. Recognize the key symptoms that barking cough and stridor. Understand diagnosis is clinical, but severity assessment, mild, moderate, severe based on stridor, recession, mental state is crucial, and management. Steroids are key, especially that single 0.15 mg/kg dexamethasone dose for everyone. Know when to add nebulized adrenaline, moderate, severe. Be aware of the key differentials, especially the emergencies, and know the common complications.
That's a great summary.
And use that structure for active recall. Ask yourself questions based on scenarios. If a child has X and Y signs from the notes, what severity is it? What's the first-line treatment dose specified here? That kind of thing.
What stands out most to you from digging into this specific set of notes?
For me, it's that really clear link they make between the clinical signs, the severity grading, and then the specific management steps tied to that grade. Especially the emphasis on that dexamethasone dose. It feels very protocol-driven, which is useful for exams.
Yeah, that clarity is helpful. Okay, as we wrap up this deep dive based strictly on the notes you shared, here's a thought to chew on. The notes mention symptoms often worsen dramatically at night. So how might you, as a clinician, combine your daytime assessment of, say, a mild case with what the parents tell you about how bad things got overnight to make a really safe decision about managing at home versus admitting, especially considering only the information laid out in these specific notes? Something to think about. And that does wrap up our focused look at Croup, drawing exclusively from these MSRA revision notes. Hopefully breaking it down like this has really helped clarify things for your study.
Definitely. Remember, getting these core concepts and the specific details from your study materials down is crucial.
If you found this kind of targeted breakdown useful for your MSRA revision, PassTheMSRA.com has a load of comprehensive resources you might want to check out.
And for free revision materials, freemsra.com is always worth a look too.
Absolutely. Until next time, keep learning, keep revising, and keep asking those questions.